Standard medicine treats the human eye as an isolated biomechanical organ, a distinct optical instrument that can be repaired, medicated, and managed independently. Early homeopathic clinicians proposed an entirely different framework. They argued that localized ocular diseases do not actually exist. Instead, conditions of the eye are strictly localized expressions of systemic, whole-body derangements. This premise relies on a specific anatomical reality. The eye operates as an integrated node, irrigated by the exact same blood and innervated by the same nervous currents that regulate the entire human torso. If the eye is merely an outward portal of systemic health, treating it with purely localized therapeutics misidentifies the clinical target. The traditional allopathic protocol relies heavily on steroidal preparations and antihistamines to forcefully halt immune reactions. Homeopathic practitioners critique this methodology as suppressive. They note that these pharmaceutical drops mask the immediate localized symptoms, leaving the underlying systemic derangement completely unresolved. The homeopathic objective operates in reverse. Practitioners utilize extreme dilutions to stimulate the body's innate immune response rather than blocking it. To properly understand this alternative clinical model, we need to map the 4 governing axioms of the homeopathic paradigm and examine how clinicians deploy sub-physiological doses to treat both acute and chronic ocular pathology. By rejecting suppressive steroids, the stated goal of this entire framework shifts away from lifelong symptom management and toward true curative resolution. This clinical framework is not arbitrary. Dr. Dewan H. Chand established that homeopathic ophthalmology operates under 4 strict sequential rules. This matrix illustrates the structure. Axiom 1 is the law of similars, using an agent that triggers symptoms to treat those exact symptoms. Axiom 2 mandates the single remedy, relying entirely on singular interventions to avoid confusing the biological response. Axiom 3 requires a sub-physiological dose. Through dynamization, the active substance in these individual vials is repeatedly diluted past the point of physical toxicity. The 4th axiom is individualization. A prescription bypasses generalized disease diagnosis. It requires mapping the total psychosomatic symptom picture of the specific patient, including a web of environmental and emotional variables. Together, these 4 axioms form a self-contained clinical logic. The treatment relies entirely on initiating biological feedback loops, rather than imposing biochemical inhibition. We can observe this theoretical framework in practice by examining the clinical treatment of environmental ocular allergies, like ragweed and pollen reactions. Dr. Edward Condrot utilizes a specific methodology for these acute reactions, often relying on allium cepa, a remedy derived directly from the common onion. The similia principle dictates this choice. Because chopping an onion induces severe eye watering, the sub-physiological dose is deployed specifically to target that exact symptom. A second active ingredient is apis, derived from bumblebee venom. Practitioners map this specific dilution directly to the clinical symptom of severe burning. This line graph illustrates the theoretical end goal of these dilutions. When a tiny vector particle intersects a hyperreactive ocular surface, the microdose forces a systemic de-amplification, causing the immune response to downregulate and flatline. By utilizing known symptom inducers, this therapeutic model turns the body's own biological hyperreactivity into the catalyst for symptom relief. While immune responses follow this logic, acute physical trauma tests the structural limits of the homeopathic paradigm. A sub-physiological dose must address immediate tissue damage. For extravasated blood, such as post-impact contusions or subconjunctival hemorrhages, the primary clinical application is Arnica montana, deployed to accelerate the absorption of pooled blood. Triage is specific to the injury vector. For blunt impacts like a tennis ball, Symphytum officinale targets the kinetic pressure wave. Conversely, a sharp, incised corneal laceration requires a distinct pathway, shifting to remedies like Ledum palestre or Staphylos aureus. Even in cases of purely mechanical trauma, the homeopathic objective ignores localized pain masking. The target remains the stimulation of systemic repair and blood absorption. The complexity of this systemic approach becomes clear when addressing the final axiom of individualization, particularly in localized pathology like meibomian cysts. Consider 2 patients with identical eyelid cysts. Their histories demand different interventions. Patient A requires thuja occidentalis, driven by a systemic history of distinct toxic loads. Patient B receives staphysagria, mapped through a psychosomatic profile linking the cyst to deeply suppressed anger. A strict clinical prerequisite governs this entire process. Any ongoing environmental causality, whether dietary toxins, airborne smoke, or adverse reactions to allopathic glaucoma drops, must be completely eliminated before a remedy can achieve a true cure. In this paradigm, the physical lesion is merely the final diagnostic symptom. The true pathology being treated always resides in the patient's holistic medical history and emotional state. Practitioners operating within this framework report notable clinical efficacy. Dr. Jeffrey Anschel observes a 50 to 80% success rate when using these sub-physiological drops as a primary intervention. Clinicians employ a tiered, pragmatic approach. They deploy the dilutions first and only escalate to standard prescription medications like Padinol if the natural systemic response proves insufficient. This tiered progression acts as a strategic risk mitigation tool. It allows the practitioner to avoid the long-term toxicity and iatrogenic side effects frequently associated with allopathic steroids. The explicit intention is to use remedies that work with the body instead of against it, thereby preserving the patient's baseline immune function. The ultimate clinical value proposition is straightforward. Practitioners use this holistic framework to achieve both structural and symptomatic relief without incurring the systemic debt of pharmaceutical suppression. This cellular model shows the stark mechanistic difference between the two paradigms, a heavy geometric shield physically blocking a receptor versus a microscopic catalyst triggering a network-wide chain reaction. The allopathic objective forces a localized canopal blockade. The homeopathic objective relies on triggering a cascade of systemic autoregulation. Adopting the similars framework forces the diagnostician to elevate their scope. They must look past the physical structures of the eye to encompass the complete holistic environment of the patient. As Dr. Chand outlined, the eye operates as a common thoroughfare, reflecting human affection, appetite, and complex physiology. Under the law of similars, true ocular health cannot be compartmentalized. It is functionally indistinguishable from the equilibrium of the entire human system.